cost-effective and more quality service can be delivered. And this can only be ensured if we can establish a strong papers and with many comments and informative presentations there. And one thing I should say that all the professors' view was how can we effectively develop our FIS system and effectively develop our paper system too. In that, you have seen in the community clinic that we are trying to develop a very strong paper system so that we can only uncomplicated cases are being treated in the community clinic, and for better we can refer them to the higher and it will cost more after some time. So that is also we should consider that and ensure that when a patient is referred to the higher facilities, and they go to the higher facilities and take treatment from the higher facilities also, so that they can be treated earlier and get cured within the right time. So, and I will thank the organizers of this committee to establish a effective and qualitative treatment for the rural Bangladesh, and I am working in that project, and I saw in the presentation from ICDR that the utilize that community clinic, then we will be assured that we will be able to develop a good health system in Bangladesh which will cover the preventive, promotive and curative care in those community clinics. And you see the CHCPs in the health facilities, that the community healthcare providers, more than 13,000 are already been recruited and trained, and they are giving service, providing service in the community clinic. And as they are just trained, I think after training, when they will deliver their service there, the situation of health together in the community clinic will improve. And in that hope and expectation, I thank all who came here, who listened all the papers and also did some questions and get answers from the respective presenters. And thank you all our friends who came from abroad to take part in this global conference on the community health. And this is the end of this paper. Thank you.
Dear audience, this is the end of this session, but we would like to invite you for the next one.
MIS or providers can see it. Having this information available could help to ensure that the HIV positive woman would give birth in the hospital rather at home, thereby providing not always be forthcoming with know its history, especially with HIV, or may not understand its importance. Quality health care depends on effective communication and complete as possible. So in summary, without key information available, providers cannot make necessary decisions for patients based on their health history or health status, representation, as well as providing safety mechanisms for providers. So in conclusion, as healthcare providers, our duty and commitment to health
Thanks once again. Now may I request Dr. Mohammed Jazil Islam for his presentation on development of integrated MIS.
Try to locate my presentation in this conference in partner. So that will be the central focus of my presentation. But as well as I am a citizen, our information is part of broader social accountability. So my focus will be in this thing, who am I? So when it was proposed to me to present something on experience on MIS for maternal and infant officer, or I did not have any, I would say, background on direct MIS. So it's my job management. And even, I would say, patients are also falls into the demand side. So this is a broader social accountability framework where decision, because MIS is not only providing information, it is also helping us to make action or decision. And saying, and it is moving faster, so it's adapting as a challenge, new frontiers like social media and health. So how to accommodate this one, and definitely the reliability, quality. One and the next one came back in 2010. So that's why finally data availability is also important. So again, I would like to focus on the data information. These are important, but most important will be our knowledge, understanding, and our wisdom to utilize this information. So I would like to conclude.
Thank you, Dr. Jelly. There are a couple of integrate different systems, different existing practices, and the convergence issues. And you know that even within the weeks and participants, we will talk about more in the open discussion session. At this stage, I would like to invite.
We got some funding through them for educational programs throughout the state. We brought nurses to Maine Medical Center to receive 5 patients to their smaller rural hospitals and teach those nurses and those doctors how to care for them.
He's 30, in next 15 minutes. So now, in between, we have a cafe session. So if you are invited to join us in the cafe session, we can working session is your please.
Request the speaker to conclude their talk within 10 minutes. So first I request Noreen Pendlebury. She will talk on scope to improve nutrition, information system in Bangladesh.
Good afternoon, everybody. Very welcome. Let me just change the title of my presentation, but this is the correct one. The Nutrition Prevention in Bangladesh. As you probably all know, but I should not make assumptions because I don't see too many nutrition cases here. We do have an ongoing, quite serious issue with nutrition in Bangladesh. Still around 40% of children sponges, and on average around 15% of children suffering from wasting, which is waste by having. The good news is that we know what needs to be done. And I'm talking, again, I'm aware I'm talking with a lot of health people, so I'm speaking from a public health point of view, from nutrition, not clinical. We know exactly what needs to be done. We have very good evidence from 22 journals, Lancet, Taking Up Nutrition, Copenhagen consensus. we know what needs to be done, and better still, we know how to do it. We know what works. The challenge for us very often, is actually knowing whether or not we're doing an adequately good job and adjusting our programs to ensure that we are. We don't need to look through this list in great detail. It's just a demonstration that we know the names of infant and young child feeding, hygiene, deworming, micronutrient supplementation, consumption of a good diet, and prevention and management of acute malnutrition. In other words, we do know what needs to be done in those are the key areas. The question is why are we very often not successful in achieving good results even though we know what needs to be done. So we agree on the intervention. And if I take an example of iron supplementation for pregnant women, it's a no-brainer, we do it, we know it has to be done, we know it works. Why do we still have such a high level of iron deficiency in India and some parts of Bangladesh? The question is, we know what's needed, we know about how to make records on service delivery, but do we actually look carefully at what we would call effective coverage? And in the case of iron supplementation for pregnant women, the effective coverage is the proportion of women who actually consume the recommended 100 tablets during the course of the pregnancy. So that's equally a used example of iron supplementation because it's an easy one to demonstrate and one we have used here in Bangladesh. But it equally applies to any intervention that we know to be effective. So if we break down the issue of effective coverage, and this relates very much to the whole collection of information and how to use information for, we look at some very key areas of availability, access, utilization, continuity, and effective coverage. By looking at each of these areas in turn, we begin to see the difference between the original target for what we intended to do and the ultimate result. What this means to begin with, and what we have tried to do here, is to define what each of those areas means for the particular issue we're looking at. This does not come on any package or textbook. We actually have to think through this in our particular context and know, for example, what is target and what is effective. If you look at that list of indicators, target, for example, is all pregnant women. Look right down to the bottom right corner, and we know that the indicator for effective cover is the percentage of women who consumed at least 100 iron fortification tablets during their last pregnancy. In the meantime, we have 3 or 4 other steps through which we can review our data to find out at which stage between what we had as a target and what we had as effective coverage, we actually fell down in our target. So we have done this in a few areas in Bangladesh, and we have actually learned a lot, and it's a learning process, and it has helped us to actually improve our programming. What we did also was that we did a little dummy version before we went to the field, and we thought, if we look at all these domains of availability and access and effective coverage, what do we think might be the reasons for low cover for iron supplementation in Bangladesh? And it's generally below around 10%. We might initially assume that we have enough supplies, but in the reality, we had assumed there were adequate supplies. If you see the very last target, that is ultimate compliance and effectiveness. So this is what we came up with, a rough estimate before we went to the field. And after we went to the field, we came up and looking at very, very specific data, we find very, very different things, different information. Going very, very quickly to the sort of the conclusion of what we use this kind of information for, one uses a mapping of the various steps and defines which are the key areas in the entire pathway where there is the biggest fall-off in cover. And that is very, very useful means of focusing your interventions on the area of biggest fall-off. It may be supplies, it may be access, it may be availability of services, it may be women feeling comfortable about coming to the clinic, it may be about women actually completing the course once they go home, even if they get all the drugs. But one has to look at each area before you actually decide on where best to invest your resources. We very often go directly into what we perceive as being the problem. Women don't like iron, or there aren't enough supply. One has to actually look at the data and use evidence to decide where along the entire pathway we have actually fallen off on our cover. What I have in other slides and what is available is further details on how one can actually do that. Ultimately, one can redo the graph and one can look at whether or not your intervention in a very specific area has an impact on cover. Our lessons learned from a few initial pilots here in Bangladesh are that this is a very useful way of targeting resources. It's a useful way of communicating with health workers, but also with policy makers on where resources need to be focused in terms of the entire health services. We're trying to look at new ways of collecting the data. We're also trying to make sure that we balance the specificity of the data with the realities of actually being able to collect that data in the first place. So one also always has to find a balance between excess information and adequate information and what is the reality. This has allowed us to really manage some of our interventions with a clear focus on results. Not a clear focus on projects, on what we like to do, what we like to support the government with, what owners like to fund, but being able to show that what we're doing is done based on evidence, and we expect to see a result, and we can actually measure that result in terms of coverage. The big issue is that when we're looking at an intervention, a public health intervention that we know can be effective, and we're not seeing the impact, we actually do need to go back to the data, and there are very easy and nice ways of going step by step, very visually, and identifying how we can do better, how we can support our programs. Thank you very much.
Thank you, Nurul. Our next speaker is Professor Parveen Fatima. She is the General Secretary of Obstetrics and Gynecological Society of Bangladesh, OGSB, and she is also Professor of Obs and Gynecology at Sheikh Mujib Medical University. She will talk on role of professional associations to integrate health management information system for maternal and child nutrition status in Bangladesh. Professor Parveen Fatima.
Good afternoon, everybody. Today, I'll be talking on the role of professional association. I being a OBGYN, my association is an Obstetrics and Gynecology Society, to improve the management of information system (MIS) for the health of the mother and the child. So, and this is the main thing is the nutrition. So today it is regarding the nutrition of the mother and the child. Nutrition is the foundation for health and development in any country, and 7 million children under 5 suffer from malnutrition in Bangladesh. While nearly half of the child mortality is attributed to malnutrition, it results from multiple causes and needs multi-sectorial care. And well-nourished children, just at the same time when you think of them, they perform better in school, which is lacking in the children who is malnourished. They do better in school and they enroll early and stay in the school for a long time, get educated, have a good living, and are more productive than the counterparts. And especially this is for the women. The girl children are being neglected, the women of the country is being neglected, so nutrition is to be given care for them also. And among the 6 countries which are taking the burden of underweight children, Bangladesh is there. 50% of the underweight children is among these 6 countries, and 1,60,000 children death occur due to chronic malnutrition. 1,50,000 children die in my country for acute malnutrition, and malnutrition in Bangladesh affects almost half of the preschool children and women of childbearing age. So, nutrition should be throughout the life cycle and meet the multifactorial approach. Eradicating malnutrition is one of the best investment government can make. Being taken care, many of the steps have been taken for that. And the malnutrition starts from the intrauterine when the child is in the mother's womb. And childhood malnutrition is very propagated. What happens due to the intrauterine undernutrition? The babies are of low birth weight and starts the life as a bad start. And in Bangladesh, prevalence of low birth weight was found to be 22% of the babies born, and the consequence of childhood nutrition, which is continuous because they are not fed properly the way they need the weaning. The first 1,000 days of child nutrition is very vital because the something that will start at this moment cannot be compensated later on. And long-lasting effects of subsequent growth, mobility, cognitive development, educational attainment, and productivity in adulthood will be impaired. And maternal and child undernutrition, regarding the maternal, inadequate dietary intake, and these two are very important. There can be long-term and short-term consequences leading to mortality, morbidity, and disability. And long-term morbidity regarding the size of the adult, intellectual ability, reproductive performance, and we know that the other spectrum of the nutrition is that stunting as well as obesity. And metabolic and the cardiovascular disease, when a stunted person becomes obese, is a problem there also. So, nutrition is very important because what impact does it give in the national way? The NDP target, to reach the NDP target, we need to improve the nutrition, to build up the economy of the country and the family and the community. Nutrition is there. Low birth rate constitutes intergenerational cycle of undernutrition and disease. So,